Good evening to everyone present here with us today. This is Shriyan from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Nitin Abhyankar. Sir is MBBS, MD, Internal Medicine, European Diploma in Adult Respiratory Medicine Consultant, Pulmonologist, and Head of the Department of Pulmonary Medicine, Pune Hospital and Research Center. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is management of severe asthma. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Thanks a lot. And I think this is going to be a very interesting scenario because severe asthma is not very often discussed in on World Asthma Day. So I think because we are more busy creating awareness about the whole story. So this is an extreme end of it, and I hope I am able to make this session interesting as well as take you through some good insights. So let me first share the screen. And sharing it. Just check this out. Yeah. Is it getting shared? Just check.
Yes, sir, your screen is visible.
Yes. Okay. Yeah. And is it on a full slide mode now?
Yes, sir, it is on the first slide.
Okay. Fair enough. Thank you. So, right at the onset, we have to define what is severe asthma in the first place. And say, if you do a look at, say, ERS or American Thoracic Society criteria, it essentially refers to the patients who require high dose inhaled corticosteroids plus a second controller, or either a continuous or near continuous oral glucocorticosteroid treatments to maintain asthma control, and many of them who never achieve control despite this treatment. So I think this is going to be the important aspect, that these are people who are not doing well despite the typical ICS LABA that we give in a mid or a low dose kind of a thing. And they need a second controller, they need an oral corticosteroid, and despite all this, they may not be very well controlled. So I think that's the bottom line. That's the second important part of it. How do you deal with these patients? For patients who are difficult to control severe asthma, essentially try and get a referral to a specialist center for further assessment, because this has been shown that it leads to improved asthma control, reduces exacerbations, and decrease oral corticosteroid use. And if you really look at the expansion of biologics which are coming in this particular territory, it becomes more so to take a specialist reference rather than trying things at a primary practice level. So I think it's going to be very important. One of the most important parts of asthma, in any case, asthma treatment plan is a written asthma plan, and often it is missing. We typically do that when people are going abroad or that kind of a thing, but it has to be for a severe asthma, it's a must. We must have an ongoing peak flow diary and a symptom score, ACT score. This the patient can keep charting. Peak flow diary is very easy to chart. And patients who are poor pursuers of dyspnea may benefit from a plan based on objective measurement of airflow limitation. Therefore, the peak flow creates a much, much better scenario rather than only symptoms. And a short course of oral steroids for patients to keep at hand and start based on specific criteria in their action plan needs to be discussed with these patients. If you have done that, you have done a great deal of service to these patients, not only these patients, to majority of the asthma patients, but for the severe group, it is even more life-saving often. The other part which must be given to these patients is a short-acting beta-2 agonist, for example, salbutamol or albuterol as it is referred to in the American context. 2 to 4 puffs to relieve from acute symptoms is what is prescribed. This may be repeated twice within an hour if needed for an acute exacerbation, but they must be used only on as needed basis. That means you don't tell them that use your salbutamol 4 times in a day, every day. That is not correct. Some patients with severe asthma derive better symptom relief by a nebulized salbutamol or albuterol compared with the meter dose preparation. So if they are more comfortable using a nebulizer, be it no issue, particularly for a severe asthmatic, it's okay. Patients who are advised to seek emergency evaluation if they are not improved after 2 hours of or two consecutive home nebulization treatments within an hour. So if they don't get better within say 30 minutes, 2 doses of say salbutamol, 2 puffs you've taken on minute C1, after 30 minutes you repeated, after at the end of 1 hour you're still not getting better, take an extra dose and move to the hospital or a emergency center. The initial therapy is very similar to standard asthma because the asthma is a disease of inflammation. So some amount of inhaled corticosteroids are a must, but for a severe asthma, we have to also keep in mind oral asthma, oral prednisolone or oral steroids. Generally, a combination therapy of two or more controller agents, and that controller agent typically will be inhale corticosteroids with a long-acting beta-2 agonist, sometimes very rarely LAMA if the patient is intolerant to LAMA for whatever reason, but mostly it is ICS and LAMA, and sometimes Montelukast and whatnot additionally. I mean, that we'll go towards that towards as we proceed in this, but the minimum required is a typical combination therapy of two or more controller agents and sometimes oral corticosteroids. Because the word severe is there, please keep this in mind that we are using the word oral steroids. This is not a standard of care for standard, garden variety of asthma. Achieving the usual goals of asthma treatment, for example, preventing chronic and troublesome symptoms, normalizing lung function, maintaining normal activity levels, preventing exacerbations, improving health related quality of life, and providing optimal pharmacotherapy with minimal or no adverse effect may not be fully possible in patients with severe asthma because these are severe patients and not controlled with the conventional therapy. Therefore, it may be some kind of a compromise where you accept some degree of reduced activity, some limitation and persistent airflow limitation may be present, and focus instead on reducing the frequency and severity of exacerbations and hospitalizations, avoiding further loss of lung function. There may be already a certain amount of loss. Somebody may be at 20-40% FEC, but you have to at least reduce it, reduce the decline, and limiting toxicity from medications. So use the least toxic medications, not a very high dose of oral corticosteroids. So that's how we are going to deal with this particular situation. So the typical role of oral steroids is in deciding when to prescribe an oral steroids. It is worth considering what is the severity of the symptom, degree of overflow limitation, and whether symptoms have been stable or worsening. Somebody who is rapidly worsening has to get oral steroids in a severe asthma context. In general, we prescribe or it's recommended that oral glucocorticosteroid, say prednisolone equivalent of 40 milligrams, to be given to these patients who have frequent daytime or nocturnal symptoms, recent worsening, increased need of short-acting beta-2 agonist. Somebody has taken 6 or 7 puffs of salbutamol in a day and still not up to the mark. Is wheezing, is breathless, is not able to sleep, and the forced expiratory volume in 1 second FEV1 is less than 60% of the predicted. We may or may not have access to that all the time. Some machines are today available which can actually give you an FEV1, but at least peak flow measurements are available. Once you are in this kind of a zone, then either a 2 weeks course of oral glucocorticosteroids or an intramuscular injection of triamcinolone may be considered in patients who have baseline stable airflow obstruction that does not reverse with inhaled bronchodilators. In this way, the degree of reversibility to glucocorticosteroids can be determined. What I'm trying to convey here is that sometimes when you see them for the first time, these patients look so bad and their lung function is so bad. Their peak flow meters are just maybe 100, 150, and they're just not reversing after the bronchodilator. But you give them a trial of 2 weeks of oral glucocorticosteroid or a depot preparation like an intramuscular injection of triamcinolone, and we assess them after 2 weeks. Use a peak flow meter chart, and FEV1 at the end of this trial may be much better. See, so they start with 40%, and after 15 days of oral steroids, they have come up to 60, 65, 70%. That means there is a treatability. And the FEV1 at the end of this trial will be the goal. For example, if they reach 70%, then 70% at the end of 2 weeks will be the final goal for long-term management rather than 80%, which will be the usual target for percentage of the predicted value. So you can't realistically aim at 80%. You'll have to say, okay, I'm happy with 65, 70, 80, 75, whatever I'm getting. Several formulations are available. When we are talking of use, we are thinking of choosing the right inhaled corticosteroids. And generally, when we are dealing with severe asthma, we choose something which is high potency, fluticasone furoate, fluticasone propionate, possibly mometasone. One of these will allow for the least number of puffs for the day. So they might be better than, for example, say budesonide. It might be a little relatively weaker, though 98% of my patients are on budesonide formoterol, but that may not be true for severe asthmatics. Most patients with severe asthma are treated with a combination of inhaled glucocorticosteroid and a LABA. And that LABA could be either salmeterol, formoterol, or vilanterol. If I can do with once in a day, vilanterol is possibly the best choice because it is the lowest dose and the best efficacious. Formoterol for people who require quick relief of action, and it is the go-to gold standard for last 30 years in my practice. It has remained formoterol. Salmeterol can be used in patients who are, say, tremulous with formoterol or some exceptional situations, but it's not my first choice. Some people may like it, but it's okay. Fine. They're all considered to be acceptable. Now, I'm not going to go through this entire laundry list of all the preparations which are available, but ranging from beclomethasone, fluticasone propionate, furoate, all that, and there are various permutation combinations. So all that will be discussed as we proceed further. Now, we are now dealing with a severe asthmatic. And why is the severe asthmatic a severe asthmatic? Why is he not getting better? I'm giving him the right medicine, formoterol budesonide, 200, two puffs twice daily. Everything is right. 800 micrograms of budesonide is going in. Why is he not getting better? It could be because there is a residual inflammation which is relatively glucocorticoid resistant. So there could be still a residual inflammation, or there could be a remodeling. That means the airway has already been remodeled and the epithelium is all gone and it's replaced by fibrous tissue, and therefore there's not inflammation. This is causing the airflow limitation. Or sometimes, rarely, but increasingly found with iOS and other techniques, that the inflammation is so distal that your inhaled medications are not reaching the distal airways, and therefore small particle inhalation therapy, for example, small particle beclomethasone may be one of the ways to go ahead. So I think this is worth keeping in mind before we going on to the next therapy. Of course, I've already talked about the oral glucocorticosteroid and intramuscular injection of triamcinolone. Increase or push up the dose of glucocorticosteroid, inhaled glucocorticosteroid, to 1600 micrograms of budesonide. Typically, say budesonide formoterol, two puffs twice daily of 400 micrograms each budesonide. Or sometimes you may have to use fluticasone propionate in excess of 2000 micrograms, or fluticasone furoate at least 400 micrograms per day, so that they are the equivalent dosages. Substituting an alternative or adding third controller agent such as inter anti-leukotriene agent, like or that means a montelukast like agent, or tiotropium needs to be considered. And once again, if they are not remaining better with this, I think this is a specialist territory. So do refer it to a specialist and consideration of the therapy with one of the biological agents. Patients who fail to respond to systemic glucocorticosteroid may rarely have what is called as glucocorticoid resistant asthma. It's a rarity, but it can be true for some patients. For clinical purposes, this is defined. How do we define it? A by FEV1 that is less than 75% of the predicted and fails to improve by around 15% after 2 weeks trial of oral glucocorticosteroid. For example, prednisolone 40 milligram per day has been given for 2 weeks and still the patient has not improved up to the mark, is not improved by FEV1 of more than 15% and it remains less than 75% of the predicted. That is where we define that, look, this person may be systemic glucocorticosteroid resistance. Now, some of these patients may be actually working over a longer period of time, giving a low dose oral glucocorticosteroids, 5 to 10 milligram per day, particularly when bursts of oral glucocorticosteroids are repeatedly required every 2 to 3 months. And people who are remaining that way and requiring oral steroid despite high dose inhaled glucocorticosteroids, long-acting inert beta-2 agonist. So that means ICS and LABA in the fullest possible dose is there. And other controller agents like tiotropium or glycopyrronium all have been tried and still they are failing repeatedly. So that's what we need to do. It must be remembered and reiterated again and again that even low doses of oral corticosteroids are associated with increased risk of comorbidities, hospitalizations, and even mortality in patients with asthma. So they must be used at the minimum necessary dose when all other approaches have failed to control asthma symptoms or exacerbations. Patients on chronic oral glucose corticosteroid must be monitored for glucocorticosteroid side effects also. So I think these are the two important caveats to this. Now we move on to what is high dose inhaled corticosteroid, and it needs to be pushed to, as I already touched upon, the 1,000 micrograms per day. For example, this is a study which shows that 671 patients with severe asthma found to have a slightly greater efficacy when they use fluticasone. This was a propionate salt, mind you, 2,000 micrograms per day compared to fluticasone 1,000 micrograms per day, or budesonide 1,600 micrograms per day. Please read that as micrograms per day. So the outcome measures when they use this particular trial by Ayers were that they were having a morning peak flow, rescue medicine, daytime symptom scores, diurnal peak flow variation. However, systemic glucocorticosteroids effects are definitely likely to happen when you are giving such high doses. So monitoring for glucocorticosteroids related side effects is also important. So some of the so-called severe asthmatics may be responsive to a higher dose of inhaled corticosteroids, but I think once again, leave this to a specialist and let him try this with a close monitoring of the lung function as well as the peak flow. And I think that's a better game. Most patients with severe asthma should receive a trial of combination therapy with inhaled glucocorticosteroid and a long-acting beta-2 agonist. I think we have already repeatedly shown that. Clinical trials and systematic reviews are increasingly now reassuring because once upon a time, there was a black box warning written by US FDA on the LABA, long-term usage of LABA. But when you use an ICS and LABA combination, then in that combination, there is no more the boxed warning that express concerns about safety of these medicines. But at the same time, let me reiterate again that LABAs are never, ever used as a, sorry, LABAs are never, ever used as monotherapy in severe asthma. It has to be ICS plus LABA and preferably, most commonly in a severe asthmatic, it will be a high dose ICS with LABA. So that is what we have to take into mind. Is there a role for leukotriene antagonists? And they have been found to be of some use. And there are various of permutation and combination. There is Zafirlukaz, it is Saluton, but what is available in India for most of us is Montelukast. And Montelukast can be used as recommended by NAEPP guidelines suggest a trial of an anti-leukotriene agent in patients with severe asthma who are not controlled on high-dose inhaled glucocorticosteroids and so that's the kind of a recommendation which is as late as 2021. So it is approved for this particular use. At least a short trial is definitely. Can we add a LAMA? For example, the classical is tiotropium, but the today's scenario, we are increasingly using glycopyramine. And this is actually a meta-analysis which particularly showed that adding a LAMA, at that time it was only tiotropium, to inhale glucocorticosteroids and LABA, absolute risk reduction was around 2%, but adding a LAMA to an inhaled steroid did not reduce exacerbation risk compared to adding a LABA. So LABA ICS was better in reducing the exacerbation risk one way or the other. Furthermore, adding a LABA or a LAMA to inhaled glucose corticosteroid regimen did not reduce exacerbation risk significantly compared to adding placebo. But the FEV1 trough was increased when you use the triple therapy. So there is some role for triple therapy here. It is not very clear how much, say, your tiotropium or glycopyramine is going to make an impact, but at least their trough FEV1 is going to get better. So possibly symptomatically, they are going to be a little better. And I think there is no harm in adding a LAMA to an ICS LAMA when the treatment is failing in a severe patient. I'm just taking this as one example. This is not representative of everything. What we have in our country is because fluticasone is a more powerful one. So I'm using that particular example. And then they studied fluticasone with a low dose fluticasone versus high dose fluticasone. So 100 versus 200 micrograms of fluticasone furet. And what they found was among the patient with a higher blood eosinophil levels, preparations with 200 micrograms of fluticasone led to a 65% lower rate of moderate to severe exacerbations compared with the preparation of fluticasone furet, which was 100 micrograms, suggesting that the glucocorticosteroid dose is the most important part of these three elements in reducing exacerbations. If you are realistically looking for symptom relief, yes, your long-acting beta-2 agonist, your LAMA will have some role to play, but the exacerbation reduction is best achieved by what is given as glucocorticosteroid dose, and that dose has to go high. So if you are using budesonide, go to 1600 microgram. If you are using fluticasone propionate, go to even 2000 microgram if necessary. But and if you are using fluticasone furet, possibly you may have to go from even 200 to maybe 400 once in a while, but that needs to be done. Now, some patients will, despite all these great things that the doctor is doing, remain uncontrolled despite high dose inhaled corticosteroids and one or more non-glucocorticoid controller medications, LABA, LAMA, or possibly a combination of LABA, LAMA, and ICS, that is a triple. Some of these patients may be candidates for biological agents. For example, immunoglobulin E, anti-immunoglobulin E, IgE, omalizumab, or anti-interleukin 5, anti-IL-5s, for example, mepolizumabs or anti-IL-5 receptors. So, for example, benralizumab or anti-IL-4, which is dupilumab, or anti-thymic stromal lymphoprotein, TSLP, which is tezepelumab. So I think we will touch upon some of these. You may or may not understand everything, but what I've tried to keep it very simple. I'm not giving you the dosages because this is a specialist job. But at the same time, I am trying to give you insight into when, what is prescribed and what is preferred. And this is because the topic is severe asthma, I cannot run away from the biologics and choosing the biologic agents correctly. Unfortunately, biologic agents for severe asthma have not been compared to head-to-head trials, and indirect comparisons have found similar improvements in terms of exacerbation rates and asthma control. Each agent will have its own particular indication, dosing, and side effect profile based on the clinical trials. As examples, only patients with Ig levels more than 30 and a presence of an atopy are classical candidates for omalizumab. Only patients with an elevated eosinophil count, more than 150, are candidates for either anti-IL-4R, which is a benralizumab, or anti-IL-5, which is mepolizumab, or other anti-IL-5R receptor therapies. Sorry, IL-4R is dupilumab, and this is mepolizumab. And the anti-IL-5R is going to be the benralizumab. And most of these studies come in adults. Most of them are not available for children. So I think that is also worth remembering. Beyond meeting required indications, you have to also try and characterize the underlying type of inflammation or the asthma phenotype, if possible, even endotype, can help you guide selection of therapy. As an example, patients in the pivotal trials of bimekizumab, dupilumab, and tezepelumab, who had also had an elevated FeNO. FeNO is an inflammatory, and high FeNO means lot of lung inflammation, airway inflammation. So if they're above 25 parts per billion, showed more robust responses to these agents as compared to the patients who are having lower ones. So these medications possibly were better when there is a lot of airway inflammation. For patients with a severe asthma but without elevated FeNO and or allergen-driven symptoms, tezepelumab still demonstrated efficacy. So tezepelumab may be a choice for people who have low FeNO. And I think this becomes an important endotyping or phenotyping, whatever is possible. So you need to work these patients up in a systematic way. When you are choosing a biologic, first of all, assess the history of childhood versus adult asthma. So the onset is used typically as more than 12 years is defined as adult onset. Assess the sensitivity to inhaled perennial allergens by either history or have they been atopic or have they been having a runny nose or skin atopy, all those, or a skin prick test or an allergen specific IgE testing. And then, in addition to that, obtain a peripheral blood eosinophil count, total serum IgE levels, and preferably a exhaled nitric oxide. So phenol is an important way to do the inflammatory. So I think all these are important. Most important is that people are trigger crazy. Like in India, people will possibly land up using a lot of oral steroids. In this is a study in from year 2022, clinical immunological practice 2022, and Bender showed that biological agents are indicated only for patients whose disease is unable to be controlled with adherence to maximized inhaler control of therapies. In one of the database analysis from the United States, less than half the patients escalated to biologics met criteria for uncontrolled patients. That means more than half the patients were actually not meeting the criteria, and over these half had evidence of suboptimal maintenance medication adherence. So they were not taking their inhalers correctly, and they were put on biologics because they were not taking their inhalers correctly, and therefore they remained uncontrolled. Additionally, nearly half the patients were only using equivalent of step 2 or step 3 gene therapy. So they were not realistically taking the high dose. There was no tiotropium added. There was no glycopyranum added. There was no bantolicos added. And directly jumped from ICS lab of medium dose to possibly to straight away to biologics. You have to remember that there is a risk, and in Indian context, a huge amount of cost when biologics are considered, and therefore it is not supported in these patients who are highly likely to benefit by increasing simply the adherence or the intensification of inhaled therapies. And therefore, verification of the persistently uncontrolled asthma is the most important step before you jump on to the next level. That is going to be very, very, very critical. Now, I'm going to take you through which biologic will work in which situation. Some part may be understood, some part you may have to read it up again, but I think I'll just try and give you a bird's eye view of this. For patients who are non-severe eosinophilic granulomatosis with polyangiitis, now this is what we call as Church-Strauss syndrome. Not so severe one, mepolizumab is a preferred therapy in conjunction with systemic glucocorticosteroid. In any case, you know that Church-Strauss requires oral steroids, but you can use in addition mepolizumab here. It's also the only asthma biological therapy approved for eosinophilic granulomatosis with polyangiitis, that is Church-Strauss syndrome. The dosing of mepolizumab for this conjunction is higher than asthma alone. Typically, you will use 100 milligrams every 4 weeks. Here, you are using 300 milligrams every 4 weeks, but it is generally well tolerated even with this increased high dose. Other anti-IL-5 or anti-IL-5 receptor agents are also being investigated as therapeutic options in these indications. So these are special situations where you may be needing higher doses or even a biologic and a biologic can be combined with oral steroids. The other good example is allergic bronchopulmonary aspergillosis. We know that somebody who's having an IgE, total serum IgE in excess of 1,500 or more than 1,000 will be considered for it. If the aspergillus specific IgE is high, then we will define it as ABP or allergic bronchopulmonary aspergillosis. These patients require very high dose of steroids, and asthma biologics are indicated in patients with ABP who have recurrent exacerbation or inability to taper the oral glucocorticosteroids. Anti-IL-5, anti-IL-5 receptor therapy, anti-IL-4, and anti-IgE agents all have been described in small case series. We prefer to use mepolizumab or benderali in these patients who have a blood eosinophil count in excess of 300, and omalizumab where there is a lower eosinophil count and a very high IgE level. So I think omalizumab also figures out that is available in India. Benderali as well as mepoli are available in India. Further studies are of course needed to determine appropriate role for these biologics in ABPA and whether any of these agents interrupt the progression of bronchiectasis and eventual fibrosis. So I think ABPA is not just an innocuous disease. It may land up in a very fibrosis and early death for some of these patients, and it might be important to find this out. Then there are a subset of patients who have what is called a CRS with NP, chronic rhinosinusitis. They have the nasal polyposis and chronic rhinosinusitis. This is a frequently encountered asthma comorbidity and sometimes treated with biological agents if the control cannot be maintained with systemic corticosteroids, sinus surgery, and topical corticosteroid maintenance, which we give to all the patients. When using biological agents to treat with patients with asthma and comorbid refractory chronic rhinosinusitis with nasal polyposis, we typically choose dupilumab due to the evidence of an increased efficacy against nasal polyposis. Omalizumab and mepolizumab are also reasonable alternatives, and these both are available in India. Dupilumab at this point in time not available in India, so we can use this in chronic rhinosinusitis with benralizumab, though available in India, does not improve long-term symptom scores, time to surgery, or chronic corticosteroid use in treatment of nasal polypus, and therefore it is definitely contraindicated. You should not be considering these. The others are getting studied. So now we'll jump on to the patients who are having different onsets and different behavior, and which biologic are we going to use in asthma scenarios. So for patients with persistently uncontrolled childhood onset asthma, remember, less than 12 years of age, the disease started. Several studies suggest that anti-IL-5 or anti-IL-5R therapies are much less effective as a class, even in patients with elevated eosinophils. So you are not really going to be doing very well if you use mepolizumab. Dupilumab in this situation demonstrates efficacy in this subgroup, although its effects are more robust in those who have a later onset. So dupilumab, omalizumab, and tezepelumab are reasonable options for these patients, with the optimal choice between them uncertain due to the lack of head-to-head comparison. So I think this is one thing which is worth keeping in mind. From our viewpoint, what we have is omalizumab. So do consider it in a childhood onset asthma, even if it is not IgE mediated completely. And it is possibly worth considering only as an only option, because we'll have to wait till Tezspire or dupilumab come to our country. It will be at least a year from now. Patient with adult onset asthma without peripheral eosinophilia. Now, this is another subset of patients. There is no peripheral eosinophilia at all. For patients without eosinophilia, here who have elevated FeNO, that means there is a lot of airway inflammation and significant allergy-driven symptoms, the drug of choice here is omalizumab. There is no doubt about it. So this is a typical type 2 inflammatory disease, which is mediated by IgE, and omalizumab is the drug of choice. Tezepelumab also shows efficacy in this group, although off-label in the United States. There is evidence that dupilumab may be effective in these patients with elevated FeNO, but without eosinophilia. For those without eosinophilia due to chronic use of oral corticosteroids, and this is something very important, because a lot of patients who are coming to you may be on, say, 5-10 milligrams of oral steroids, and therefore you're not getting the eosinophils. So taper it off for a little while and see whether you are getting high eosinophils. And once you get high eosinophils, your choice of biologics will change. Both anti-IL-4R and anti-IL-5 agents have shown efficacy in dose reducing and eliminating oral glucocorticoids in those with type 2 inflammation and systemic glucocorticoid dependent disease. So consider in our situation, Mepoli or Benderli can be considered in this situation. A little about tezepelumab, it's likely to come among the biological agents. Tezepelumab is the only agent shown to reduce exacerbation rates in patients without either peripheral eosinophilia or allergen-driven symptoms. So, allergen-driven symptoms, you will typically think of omalizumab. Peripheral eosinophilia, you will think of either Mepoli or benralizumab in our setup. This is one end. That's why I'm mentioning this, though it is not available. This is preferentially used in patients without signs of type 2 inflammation or for those without peripheral eosinophilia who do not qualify for omalizumab. It has also demonstrated efficacy in those with type 2 inflammation, but there is less clinical experience with this agent. While awaiting additional clinical experience and observational data regarding comparative efficacy, we do not typically use this as a first line agent. So your first line should still maybe Omali, Nepoli, Bendrali, so on and so Resli and so on and so forth. The other Resli is not yet available in our country. So then we move to another phenotype, which is patients who have a modest elevation in peripheral eosinophils. And if you look at the eosinophils, they are sitting anywhere between 150 to 300. Now, dupilumab once again is highly effective in these patients who are sitting in this particular zone. In these patients with lower elevations in eosinophil, post-hoc analysis demonstrates a 40% reduction in exacerbation rates with dupilumab. Tezepelumab also has demonstrated a 40% reduction in the exacerbation risk. In contrast, the positive data for IL-5 and IL-5 receptor agents, Mepoli and Benderli, are more convincing when you have higher, that means higher than 400. So do not try this in these patients. They possibly may not be work. And once in a while, let us not forget our good old omalizumab for patients with evidence of allergen sensitization, even with those who are mild eosinophilia. 150 to 300, omalizumab still can be considered, particularly if I have IgE, which is elevated more than 30. So I think that is something worth keeping in mind. Now we come to another subgroup of patients, and this subgroup is adult onset asthma and large elevation in peripheral eosinophil counts, which is anywhere between 300 to 1,500 micron. 1,000 cells. Now, because anti-IL-4, anti-SLP, anti-IL-5, and anti-IL-5R therapies are all effective for patients with adult onset asthma, whose disease is driven by type 2 eosinophilic inflammation, there is an abundance of choice here. So you can use dupilumab, you can use tezepelumab. Typically, the dupilumab is the first choice where it is available, but the remainder of patients with elevated eosinophil, even Benderali can be used given its 8-week dosing because it's a preferable one. Mepolizumab is also preferred in some patients with nasal polyposis, but benralizumab is not effective in nasal polyposis, and nasal polyposis coexist on nasal polyposis. Cross out benralizumab. That is the simplest message. Of course, reslizumab, the issue with reslizumab, even if it comes here, is IV preparation, and that is something which you have to keep in mind. And interestingly, in this subgroup of patients where we are anywhere between 300 to 1,500 eosinophil counts, omalizumab is effective in reducing exacerbation rates with peripheral eosinophils who otherwise qualify for omalizumab based on the elevated Ig level. So if I have this is typically described as overlap. So you have both. You have a little increase or there will be a substantial increase in eosinophils, but there is an elevated Ig level also. And this agent is therefore also a reasonable option for some of these patient populations. So you have a wide choice when you are dealing with adult onset asthma who's sitting between 300 to 1,500 eosinophils. That is going to be an important point to be kept in mind. Now we are talking of hypereosinophilia, which is in excess of 1,500. I'm not talking of ABPA because ABPA is more or less ruled out. There is no aspergillus specific IgE documented. IgG for aspergillus is possibly negative. Patient with this degree of severe peripheral eosinophilia should be evaluated for specific cause for hypereosinophilia that may require alternative treatment strategy. In patients with such severe elevations in peripheral eosinophil, dupilumab should not generally be used as it may increase the risk of eosinophilic vasculitis. So dupilumab is sort of contraindicated in this sort of a situation. Due to their robust anti-eosinophilic properties, either a mepolizumab or a benralizumab are possibly the mainstay of therapy for this group where there is no alternative cause can be identified. So if I have nothing else to offer them and they have persistent hypereosinophilia and no alternative cause is found, use either mepolizumab or benralizumab. But please make sure that you're not using dupilumab in this because it will increase the risk of Church in that kind of a situation. So I think it is something worth keeping in mind. Now we are coming towards the other part of it. So far, we have discussed what is called as Th2 high asthma, which is severe. Now we are talking of Th2 low asthma. And in Th2 low asthma, where we are neither documenting a very high eosinophil level, we are neither documenting high IgE levels, then we have to think of other alternatives. And low dose macrolides has been shown to be having, apart from its antimicrobial actions, also has anti-inflammatory actions. This is the AMAZES trial, which is 420 adults with asthma that were poorly controlled despite therapy with an inhaled glucocorticosteroid and a long-acting beta-2 agonist were assigned to add-on therapy with azithromycin 500 milligram or a placebo 3 times weekly for 48 weeks. And what was realized was azithromycin decreased the rate of exacerbations and improved asthma-related quality of life with some suggestion that the treatment worked better in eosinophilic patients. Now, this is a little confusing because one trial, which is AMAZES, showed it works a little better in eosinophilic patients. Diarrhea was an important side effect in some of these patients. And of course, if you have a QT prolongation or hearing impairment, you will not be considering macrolide because it will worsen both. So then the Aziz SAST is the small trial which showed that these patients were given no significant group differences noted in exacerbation in lower respiratory infections, pulmonary function, use of rescue medicine. Significant improvement was noted in asthma-related quality of life correlation in azithromycin. So at least the least that low-dose azithromycin was doing was that. And in a pre-specified subgroup analysis of azithromycin, decreased exacerbation in patients who were non-eosinophilic asthma. Now, we have two trials, one which I already showed you, the last one, which showed that high eosinophilia, it was working. Here you are showing low eosinophilia, it is working. Possibly it is working in both, so it's not worth discarding as an option because it's a cheap option. So a severe asthma, non-responsive to anything else, a low dose azithromycin on long-term basis can be considered. In any case, it is considered in COPD. So an asthma which has become a COPD, we in any case use it. And in addition, there is if there is a recent mycoplasma or chlamydia related increase in the worsening, then a 4 to 6 weeks of azithro or clarithromycin is in any case indicated. So it is worth considering. So I think it is something worth keeping in mind. Low dose azithromycin is a good choice. Bronchial thermoplasty, this is a contentious issue. Fairly expensive, cost is around 5 to 6 lakhs. 3 sittings are required. What is done? It is applying heat via a device which will deliver localized controlled radio frequency waves to the airways during a bronchoscopy. So in a bronchoscopic setting, you go one by one and you sort of burn the segments or heat the segments from inside. And the patients who meet these criteria are, well, I mean, the data is so wishy-washy that the recommendation at this point in time is if you are going to do bronchial thermoplasty, it should be done in the context of either a clinical trial or a registry maintenance so that the data will emerge on this. And at this point in time, the focused update in NAEPP is conditionally recommended against BT because of the low certainty evidence of benefit and of course in the Indian context, a lot of cost to it also. So bronchial thermoplasty is approved for asthma usage, but in severe asthma territory, it is going to be a little contentious. Plus the idea that you are going to be actually, even if you qualify for it, you will get an exacerbation when this heat is applied and you have to go through 3 of those sittings. So that is a little bit of a problem because you don't have very solid data on this. Plus, all these trials which have been done so far, they have shown that they have taken FEV1 more than 50%. So they have excluded all the severe ones. So the data just not on at this point in time in the severe asthmatic setting. So one way or the other, several trials of systematic study have assessed the efficacy. Overall, BT compared with the sham procedure does not improve asthma control or hospitalization. They may reduce severe exacerbations. So the severe exacerbation may be the only golden point which is worth looking at. And one systematic review and meta-analysis included 3 trials and found improved quality of life at 12 months that did not reach clinical significance. No difference in the symptoms and no difference in the pulmonary function parameters. So I think bronchial thermoplasty at this point in time, I will keep out of my choices, largely speaking. Most of the you need to look and wait for better data and more data, and that I think that is what where I will stop on this. Theophylline, though mentioned by the up to date as a rarely used medication, we universally use it. Let me tell you very frankly, I use it in all severe asthmatics, but I use it in a very tiny dose of 100 micrograms or 200 micrograms per day, not exceeding 200 micrograms per day. Sustained release action. Don't use 400 BID, doxophylline 600. Those high doses are not recommended. Sustained release theophylline, 1/4 tablet is good enough. Has been used as the additional controller agent. The data is lacking regarding its efficacy, usually not as efficacious as lavas when compared head to head. And we are not trying to do that because this is an add-on therapy. But there's an interesting study which showed that studies, when we withdraw theophylline from patients with severe asthma, they had higher asthma flares, suggesting that theophylline may be playing a role beyond its weak bronchodilator capacity in the terms of some kind of immunomodulatory protection. Disodium chromoglycate, 3 or 4 times in a day, not really available, and I am not really going to go after this particular agent because it's not A, not easily available, B, not that efficacious. So I think in a severe asthma setting, in a mild asthmatic, I might search for it, but in a severe asthma setting, I'm not going to use it. So let us first once again remember that I've used everything else and I'm adding theophylline. I've used everything else and I'm thinking of chromons. These are not as first choices at all in severe asthma, but they are, and therefore they are mentioned as rarely used agents. So with that, I conclude my talk, and I'm open to any questions if you have any. And I'm very thankful to the IGCP group for giving this opportunity to me to present this on World Asthma Day. Thank you very much.
Thank you, sir. Sir, we do have some question if you like to take that up.
Surely.
So, sir, the first question is, what strategies can be employed to minimize the long-term use of oral corticosteroid in patient with severe asthma?
Yeah, I think the first and the foremost is going to be push up the dose to a higher dose of inhaled corticosteroids. The bottom line is going to be very important there, that push that dose to a higher dose. Use maybe up to even 2000 or at least 1000 micrograms of fluticasone propionate or fluticasone fumarate. If you are using, use it maybe 200 is what we use it in a moderate asthma, use up to 400 micrograms. So you may have to push that dose up. So that is the first bottom line. Of course, getting a great LABA is a great idea. So long-acting beta-2 agonists and ultra-LABA like vilanterol is definitely possibly a little better thing. Think of a triple like umeclidinium, vilanterol, fluticasone. So you may consider umeclidinium, you may consider glycopyrronium, you may consider eclidinium, or you may consider titoprium. The titoprium is the cheapest and widely available. So do that also in addition. So if you have done that, then consider adding Montelukast, because if you're not adding Montelukast, please do add it. I would add theophylline in India in a low dose without much hesitation. I'll do that. I will also consider if there is a TH2 low kind of an asthma and is requiring steroids one way or the other, then I will consider using low dose azithromycin also. So I think it is something which is worth considering. And beyond that, of course, there is a clear-cut role for using a biologic. If I use a biologic, most of the biologics will at least minimize the necessity of steroids. Most of my experience has been somebody who say uncontrolled on 30 milligrams of oral corticosteroid does come down to 6 milligrams, or sometimes even goes completely off it, because I am adding a biologic and then choosing an appropriate biologic for an appropriate patient. We have deliberated it adequately, I guess. So I think that will be one of the important choices. I hope I have clarified most of the doubt.
Yes, sir. That's right. Thank you, sir. So the next question is, what are the challenges in ensuring patient adherence to treatment regimens in severe asthma?
I don't think you have to convince severe asthmatics to really adhere to therapy. It is the mild asthmatics who actually don't adhere to therapy, and the poor perseverers who don't adhere to therapy. Severe asthmatics are so bad. Their nights are so poor in quality. They are not able to sleep. They are coughing all the time. They are restless. They are not able to perform their daily activities without getting breathless. So I don't think there is a real problem of adherence in this, except one very important is cost. In Indian settings, I see people giving up on, say, omalizumab in 2 months, when actually we are supposed to wait for 4 months for its efficacy to establish. But just because the patient is not affording it, he might go off it. And that might be a big important bus missed one way or the other. I feel increasingly the insurance, asthma insurance is of importance, and that might actually get rid of this cost issue for large number of these patients. And a very, for every asthmatic who is documented to be asthmatic, a insurance plan is worth offering, which will cover their biologics if they need one. And I'm sure there are so many asthmatics in this country that insurance companies also can provide them. Of course, getting the cost down is one method, but getting an insurance coverage will be probably another method, which will take care of this cost issue being the real bear bug. If you really ask me, why do I have only 25 patients on omalizumab? Because it is costly. Why do I only 4 patients on benralizumab? Because costlier. That's the problem. So I think getting the cost down is one, and getting an insurance cover is another. These are the two approaches which can make in the whenever in a severe asthmatic setting, when everything else is done and biologics is the only answer, I will consider getting them insured if that is possible in advance before they become severe asthmatic. So the asthma, as soon as it gets diagnosed, it is a good idea to go for insurance. And the asthma packages may be different from the rest of the thing. For example, an extra premium may be charged for it, but it is worth it, because in the longer run, the cost of, say, benralizumab in our country is around 5 or 6 lakh rupees per year, though it is only 7 doses, but it's a fairly high cost. So I think that is something which is going to be important. So I think worth keeping in mind.
Thank you so much, sir, for answering all our questions. That's it from our audience, sir. And before concluding today's session, sir, any last remark from you?
I think my last comments is severe asthma is going to be on the rise, because asthma is on the rise. So if you see asthma, managing mild asthma, early childhood onset of asthma, adult onset of asthma, eosinophil based asthma, everything is important. Doing it early, if you do it early and right, a smaller number of patients will reach there. But if you really see the denominator and the urbanization that we are going through and the so-called hygiene hypothesis, keep that in mind, because we are not in contact with the mud and the soil in the truest sense of the word, because we are all concretized. So we are going to see increased asthma, particularly in an urban population, particularly in children, and be ready for more severe asthma one way or the other. Even if we manage it extremely well, some people will require, and that number is going to be still huge in the context of a country like ours with 140 crore population. So I think we have to be ready and geared up to manage severe asthma in future, more severe asthma in future. It will not be huge numbers, but it will be still large numbers, because our country size and the population size is so huge.
Thank you so much, sir. Thank you for joining us today, sir. And with your permission, sir, I would like to conclude today's session.
Absolutely. Thanks a lot. I enjoyed doing this session a lot. Thank